Hello and welcome to Doc AT. In today's video, we're diving into the critical topic of hypovolemic shock. What it is, why it happens, its pathophysiology, causes, symptoms, diagnosis, and treatment. Let's break it down together. If you like this video, please thumbs up, comment, and subscribe. Pathophysiology. Hypovolemic shock occurs when there is a significant reduction in intravascular volume, leading to decreased venous return, preload, and cardiac output, which leads to decreased tissue perfusion. In hypovolemic shock, a decrease in intravascular blood volume leads to a reduction in preload, which subsequently reduces stroke volume. The diminished stroke volume triggers compensatory mechanisms, including an increase in heart rate, enhanced contractility, and vasoconstriction. This triggers compensatory mechanisms such as the baroreceptor reflex. Activation of the sympathetic nervous system leads to increased heart rate and vasoconstriction. Renin-angiotensin-aldosterone system. Activation of the RAS leads to sodium and water retention. Causes: loss of blood or fluids resulting in reduced circulating blood volume. Loss of blood may be due to hemorrhagic or non-hemorrhagic causes. Hemorrhagic causes include trauma, e.g. road accidents, stab wounds. Gastrointestinal bleeding, e.g. peptic ulcers, esophageal varices. Ruptured ectopic pregnancy or ruptured aneurysm. Postpartum hemorrhage. Non-hemorrhagic causes include dehydration, severe diarrhea, vomiting, burns, or excessive sweating. Third spacing. Fluid shifts from the blood vessels into tissues, e.g. pancreatitis, peritonitis, or severe infection. Symptoms. Early symptoms include restlessness, tachycardia, cold extremities. Decreased skin turgor, dry mucous membranes. Late symptoms include hypotension, weak pulse, oliguria, less than 0.5 milliliters per kilogram per hour urine output, or anuria. Altered mental status, such as confusion, lethargy, and restlessness. Diagnostics. Diagnosis is often based on clinical symptoms, patient history, and lab tests. Blood tests. Hemoglobin/hematocrit for hemorrhage, lactate-4 tissue hypoxia, ABGs4 metabolic acidosis, and electrolytes sodium, potassium to evaluate dehydration. Imaging, ultrasound fast for internal bleeding, chest X-ray or CT scan for trauma-related injuries. Monitoring, central venous pressure, CVP, SCVO2, central venous oxygen saturation. Management, resuscitation, airway and breathing, oxygen supplementation. Circulation, IV fluids, S crystalloids, normal saline or lactated ringers, and colloids and burns. In hemorrhagic shock, blood transfusion, 1:1:1 ratio of RBC FFP platelets. Definitive treatment, control bleeding by direct pressure, tourniquet application, surgery, or embolization. Treat underlying causes, e.g. antibiotics for sepsis-induced third spacing. Vasopressors if fluid resuscitation fails, but only after adequate volume replacement. Monitor central venous pressure and urine output for fluid responsiveness. Thanks for watching Doc AT.